Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome to today's episode of The Golden Hour. I'm your host, Dr. O, and today I'm joined by Brian Levine. Brian is a board-certified reproductive endocrinology and infertility specialist. He attended New York University School of Medicine and is the founding partner and practice director of CCRM New York. In 2021, he founded Nodal, a healthcare startup focused on fixing the broken system of gestational surrogacy in America. The platform seamlessly connects surrogates and intended parents while eliminating the most common pain points for them both. Dr. Brian Levine leads the industry in normalizing open dialogue about infertility, and I'm honored that he's able to join us today. Welcome, Brian.
Thank you so much, Dr. O. It's truly a pleasure. And, we got connected by one of my friends who also is an REI in the Bay Area. Mm-hmm. So it just goes to show that even though we're on different coasts, it's a very small world.
It's a very, very small world. I think one of the things I've loved the most about doing the podcast so far is actually connecting all of us who are impassioned about women's health, maternal health in one pocket in conversation. I think it's so easy for me as an OBGYN to feel siloed. I have our mutual friend, Eduardo Harrington. I have my specialists I refer my patients to. I have my own colleagues I see and talk to the most, but being able to branch out and meet different specialists in our field, coast to coast, internationally, it's just so inspiring for me. So I am so happy to chat with you today.
Awesome. Well, let's get to it.
Yes, let's jump in. So I'd love, Brian, to just learn about your own personal story. What made you decide to specialize in fertility? I think most of us go to OB/GYN residency. Some know going into residency what we want to do. Some of us figure out along the way. What was it for you?
I've kind of had a circuitous path my whole life.
Yeah.
I went to Cornell for undergraduate. And when I was at Cornell, I was pre-med. And I was like, I want to be a doctor. In fact, I'd wanted to be a doctor for as long as I could talk. I remember going to my pediatrician and wanting to be a doctor. I remember being an adolescent and volunteering in hospitals. And I went to Cornell, and I remember on that first day of college in the pre-med meeting, they said, look left, look right. Neither one of those people will be doctors. And I was like, holy sugar, this is going to be a rough journey.
Yeah.
And then 3 years into college, my dad died of cancer, and he died of pancreatic cancer, which is a terrible disease.
Yeah.
And it was at that moment, through that experience, that I really thought healthcare was a joke. And I was like, this is all a sham. This is not real. It's all about just getting people who are like easy wins, and no one wants to take care of the tough patients. And I really was disenfranchised with the healthcare system. And I was like, the only change that's going to happen is on the genetic side. So maybe I should shift paths and not take care of people and instead work on solutions to problems like cancer. And it drove me to want to be a geneticist. So in fact, I graduated from Cornell and I went to graduate school to go get an advanced degree in molecular biology and genetics. And I was going to be in the first PhD program at NYU in molecular biology and genetics back in 2002. The Human Genome Project was only 5 years old.
Yeah.
Well, it ends up that my advisor left NYU to go become the chairman of OBGYN at Yale. And I was kind of left in this advisorless role. And in the first few weeks, I realized that I want to do a PhD in something that no one really knows what they're talking about. And then they told me it's going to be a 10-year PhD. And I was like, okay, I am not signing up for 10 years to just be like Ross on Friends.
Yeah.
So I got the master's in molecular biology and genetics, and I dropped out of the PhD program. I then decided, you know what, I'm going to try med school again. So I applied to medical school. I got accepted to NYU, which was my dream medical school.
Yeah.
And on the second day of med school, the most amazing lecture in my life happened. So on the second day of med school, I heard a lecture from this guy, Jamie Griffo, who runs the fertility program at NYU. And he talked about the genetic testing of embryos and the preventing of passage of disease. And I was like, oh my God, this is my aha moment. This is what I want to do, is I want to do clinical genetics and help prevent disease and be on the happy side of healthcare. So I'll never forget. I sat there. I think I drooled on myself. My mouth was open. I'm like, oh my God, this is real. I then go home that night. I call my mom from my Palm Trio back when those were like devices. And I'm like, mom, there's this field where you actually get to do clinical genetics and you get to do the world's smallest surgery, which is like taking single cells out of embryos. And it's amazing and it's high tech. And I'm a geek. I'm going to do this. Her response, oh, geez, you're dropping out of med school? And I was like, no. I got to be a doctor to do this one. Like, there's no more dropping out. Like, I promise I'll do it. Yeah. And it was literally that moment. It was that moment on the second day of my first year of med school that I decided I wanted to be a fertility doctor. I spent the next 4 years of med school being the most annoying medical student on earth. I was Dr. Griffo's shadow. I would skip class to watch him in surgery. I would come in on the weekends to watch him do retrievals. I found myself in that laboratory watching eggs being retrieved and cleaned and fertilized. And in fact, I was working on egg freezing research in 2004 before egg freezing was even a thing, right? It didn't become commercially available in the US till 2012.
Yeah.
So it was in medical school that I solidified my desire to become an REI. Wow. But as you know, as an OBGYN as well, just because you want to be an REI, it doesn't mean you will be an REI.
Yep.
Because there's only 45 of us who graduate from training a year in America. It's a very small field.
Yeah.
So I went off to Columbia with one goal in mind, to get the best comprehensive OBGYN training possible.
Yeah.
And if I get to be an REI, then I win. And if I don't, I still would be happy being an OBGYN. So literally, I went through residency in this schizophrenic state, being like, I want to be an REI, but if I don't get to be an REI, maybe I'll be a critical care MFM. And I literally went through having these two career paths as backups because I didn't know which way it was going to go.
Yeah.
And it ends up, I was very lucky and fortunate that I matched at my dream program.
Yeah.
And I was very lucky that I got to train at Cornell, which is one of the top fertility training programs in America. And here I am today. And I get to actually do what I love, which is to help people start, grow, and complete their families.
Yeah. Man, Brian, I got chills when you described your aha moment. And I don't know how many in our field of medicine or OBGYN have those moments. I want to assume many do. My aha moment was in college when I first learned about health disparities and learning how I'm a Nigerian American. And so learning how within one generation, if you took a population of Nigerian women compared to Nigerian American women compared to African American women, in one generation, you can see birth outcomes suddenly change drastically. That was what moved me personally. That was my aha moment of, I need to be an OB. I need to make a change. I need to be in this field. And so hearing someone with their aha moment, like I said, gives me chills because it's a thing that drives us, right? That you had a circuitous path to this point right now, but it was a path that was well motivated. And yeah, I'm so glad that everything worked out.
By the way, I wouldn't change a thing.
Yeah.
You know, life takes turns, and when it gives you lemons, you make lemonade.
Yeah.
And I wouldn't change a thing. Like, I am so forever grateful that I started grad school and dropped out. I'm forever grateful for the time and effort that people put into me as mentors along the way. Because, right, it's a community, right? Like, I'm the result of a community of people that supported me to fulfill my dream. It's the best. And I love what I do.
Yeah, your enthusiasm is palpable, even though you are literally on the other side of the coast right now. Like I'm infused with you. Like I can tell how energized you are by what you do. And this is why we're talking, because I want people to learn and hear from an expert who's truly passionate. So, and we just begun. Well, we haven't even started yet. This is great. So I have my lens as an OB about surrogacy, but that lens is, to be frank, limited. There are many things that motivated this podcast, but selfishly, I do this podcast for me to learn, for me to be a better provider, for me to support my patients and their families better. Can you tell us more about surrogacy and some of the most common misconceptions around that?
Yeah. I mean, it's unfortunate that we only have an hour because I could go on for days.
Sure. And I'm sure.
The reason is that gestational surrogacy is poorly understood by our community of providers. And if your doctor doesn't understand something, how can your patient, right? Like full stop. If you don't know what you're talking about, how can your patient know what they should know and what's real and what's not? So let me take you back for a little bit to explain my path to surrogacy. Because, right, this is a very small subset of what fertility doctors do, but it's a large part of my practice.
Yeah.
And so effectively, in 2021, when Cuomo was the mayor of New York State, he did two really cool things. And by the way, you don't often hear doctors talk about cool things in public policy, but he did two really cool things. The first is, in the budget of 2021, he said that gestational surrogacy would be legalized in New York State. Before that, it was illegal in the state of New York. What that means is there was no criminal charges if you did surrogacy, but there was no contractual protections for the intended parents or the surrogate going through the process. So New York, Louisiana, and Nebraska were the three states where surrogacy was illegal. And there were 47 other states in America where surrogacy was legal. So he legalized it.
Yeah.
And the second is, he said that New York State was going to be like some of the other great states, like California just did, where if you have 100 employees or more at your company, you need to offer a fertility solution that's employer-based. So, having these employer-based benefit solutions as ways to pay for fertility treatments was really important. And by the way, this was an amazing moment for New York. This was an amazing moment for the largest fertility capital in America, right? People forget that there's more fertility treatments on the island of Manhattan than any other 5 square miles in America. And so this was huge.
Yeah.
And then something really crappy happened. Supply and demand economics took hold. When the floodgates opened and surrogacy became permissible, and embryos were easy to create because your employer would pay for it, the cost of surrogacy went from $75K to $150K, $250K nearly overnight because people got greedy.
Yeah.
Now, full transparency, I would have been A-okay with surrogacy costing 3x if it's because the woman doing the heavy lifting was getting paid more and she was demanding it. If I would have learned the surrogates unionized in America and they're like, we want better pay.
Yeah.
All for it. But that's not what happened. What happened was the surrogates were getting a minuscule bump, like a cost of living bump. They went from $45,000 to $48,000 of compensation, maybe $50,000. But the broker or the middleman went from getting $10,000 of fees to getting $75,000 of fees. And the way that they justified their fee base was saying was, oh, if you go with me, we'll match you faster and we'll get you through your clinic easier. And they were fear-mongering the F out of our patients every day. Now, you and I just met, but I can tell that we're friends already. And I can tell that you and I both had a moment in medical school that was sacred. And that moment was on graduation day when some people call it hokey and I call it transformational.
Yeah.
When you stood up to take the oath of Hippocrates, where it is typically summed up by one phrase, which is to do no harm.
Mm-hmm.
And that oath is what drives me, and I think many other ethical physicians every single day. And intrinsic in that oath is to do no harm for your patients, but also to protect your patients from harm. And I felt that the system was broken.
Yeah.
Because surrogacy in the United States is barely regulated, right? Donor egg, donor sperm, and surrogacy all fall under the purview of the Food and Drug Administration because it's all deemed as third-party reproduction. By the way, they also do tissue banking. They also do organ donation. They also do food safety, vaccine safety. They have a bunch of other things. They've got a lot on their plate.
Yeah.
But I felt that if I didn't try to change the system of surrogacy, I was complicit in the problem. And I was just as guilty to blame for the way the system was created. So let's stop there and go backwards for a minute.
Yeah.
How was the system created? So the system for surrogacy was created in the mid-'80s. And people forget that the greatest innovations in reproductive medicine all happened in the 80s. Right? Mary Beth Whitehead, baby M, the most famous case of surrogacy went to the Supreme Court in the 80s. It happened in New York State, and that's why surrogacy became illegal. But in that case of surrogacy, what happened was the Supreme Court said that the contracts are binding and that you need to actually respect the wishes of the origin of the embryo. Now, in the East, surrogacy was done where it was the same woman's egg in the same woman's uterus, where you basically did what's called an IUI. Right. So the husband's IUI or the male partner's sperm was put back inside of her with an IUI, and that's how she got pregnant. Now, gestational surrogacy, the way it's done is an embryo transfer. But the concept was still the same, which was contracts need to hold. So because of that Supreme Court case in the 1980s, surrogacy got shut down in New York. But in the rest of the country, surrogacy flourished. And the way that it typically worked was that a prior surrogate or a highly motivated individual who had some sort of experience could create a company called an agency. And they became the broker. They became the matchmaker.
Yeah.
And they would introduce intended parents who wanted a kid with a surrogate who wanted to help someone have a kid. And they'd make a match. And then they would help navigate the journey. And that's called case management. And that system started in the 80s with a lack of regulation and a lack of oversight. And in my opinion, a lack of adults in the room, because it really was almost like little startups, people without medical knowledge, people without medical training, people without social work degrees, like literally like in people's basements, you had these agencies. And today there's around 450 agencies in America. The same number of clinics that we have in America, by the way, which is also fascinating. Like they're everywhere.
Yeah.
And what happened was through the 80s and the 90s, we had some real capitals of surrogacy erupt. So California has always been the capital of surrogacy in America. California has the most protective rights of both the intended parents and the surrogates, and places like San Diego Fertility Center and the city of San Diego are really the epicenter of surrogacy in California. Also, San Francisco became a huge center for surrogacy because of the gay male population, because that's the only way that two guys can actually get to have a kid or a single father by choice is through surrogacy. But what happened throughout the years is that no one really talked about surrogacy. People ended up in surrogacy in a weird way. Couple embryo transfers didn't work. Let's explore surrogacy. You're a gay man. Let's go explore surrogacy. And there's never really been a structured way of how it works. And in fact, I can tell you, I trained at one of the best programs in America. We never talked about it because it was illegal in New York State.
Yeah.
My education was devoid of even knowing about how surrogacy works, knowing about, how do you get a contract done? How do you support the rights of the intended parents? How do you support the rights of the unborn? How do you support the rights of the gestational carrier? How do you medically manage someone who's not your patient but's carrying your patient's embryo? Like none of that was trained. I learned that all in practice. But as surrogacy continued to flourish in America, it never got out of its infancy stages, even today. And here are some crazy numbers for the people listening, because I'm a data guy, right? And I love numbers.
Hit us.
So in America, you have approximately 5,000 to 8,000 successful journeys of surrogacy a year. That's it. 5,000 to 8,000. Now, by the way, adoptions in America have gone down dramatically. So surrogacy should have gone up reciprocally.
Yeah.
It should have made sense. And today we know that 5,000 to 8,000 number is approximately only 8% of met need. Said otherwise, 92% of the need in America is unmet. And if you ask people why haven't they actually pursued surrogacy, either because they've made embryos or they're about to make embryos, they tell you the number one reason is cost.
Yes.
Because it is the cost has really gone unchecked. Second, to go through surrogacy is not easy. It's long, it's arduous, it takes a lot of collaboration and coordination, and it takes a lot of care. And so the agency really is a valuable partner of the clinic. But the agencies are so disparate and they're all over the place. And by the way, the agency clinic relationship is all driven by the intended parents, who quite often fall victim to internet ads. Pay this, match faster. Pay this, find your dream surrogate. Pay this, you'll get that. And then the clinics are the ones who ultimately have to approve the surrogate to go through the process. So it's a broken system.
Yeah.
And that's why I started Nodal, was to help fix this broken system.
Yeah. Yeah. Well, Brian, I've learned so much in the past, we've had 20 minutes together, because I didn't know the history of surrogacy in the US, let alone within the state of New York. I think as an OBGYN, I have again, the general concept of surrogacy that I got from residency, but it never felt like it was in depth enough, let alone as an REI, learning that you too did your fellowship training still with only an inkling, not even talking about it because it was technically illegal in the state of New York at that time. I think so much of this podcast for me personally came from my own frustrations with the job I'm able to do as a general OBGYN, the ways that I'm able to support those who are starting families, those who are pregnant, those who are postpartum. And so you very similarly, although you're doing it on a grander scale because you've created Nodal, but you too are taking your pain points and you're doing something very productive about it. And so I'm in awe because I just had no idea how. I had a sense of how messy it was. I had a sense of how fractured it was, but I didn't realize how complex and how broken, surrogacy has been in the US and still is to this day.
So I'll give you another example.
Yeah.
As a fertility doctor, I sit in front of a lot of people, and it's a privilege, right? Like, I actually feel like it's a privilege to be a doctor. Like, it is very rare to talk to any of my friends who are not doctors and hear them say they love their jobs. Like, I love my job. Like, I love it. Like, I think about it. I dream about it. I do it. But there's a bunch of people who need to pursue surrogacy for different reasons.
Mm-hmm.
It could be someone born without a uterus who's a female. It could be someone born without a uterus because they're male. It can be someone who's been told not to use their uterus because they've had the devastating diagnosis of cancer or hormonally receptive tumor or something like that. It could be someone who can't get pregnant, recurrent implantation failure. It could be someone who can't stay pregnant, recurrent pregnancy loss. Or it could be someone who's a single mother by choice who's choosing to pursue surrogacy so that she can continue her career and not be offloaded by the risks of pregnancy. And and I know there are certain populations that are very at risk if they get pregnant.
Mm-hmm.
So there's a lot of different reasons why people go through surrogacy. But in America, typically you sign up with an agency, and this is like how it works, is you sign up with an agency, and an agency does a search, and they identify someone who meets the criteria of what you're looking for. Let's just say you want someone who's going to deliver in LA because you live in LA, or you love your OBGYN at Cedars-Sinai and you want her to deliver your kid, or you want someone in driving distance, or you want someone who's willing to have twins for you, like whatever. You find that person. And then the agency has identified a bunch of surrogates in the waiting, and then that surrogate is assigned to an intended parent. Now, imagine you're an intended parent. You've put down a $65,000 deposit with this agency. You will fall in love with every woman who's presented to you because she's the key to you starting, growing, or completing your family.
Yeah.
But that doesn't mean the surrogate loves you. And in fact, there's a 20% dropout rate in America where people say it's not a good mix. And and I know that when expectations are not met, it leads to dissatisfaction and frustration. So when I started Nodal, I flipped the script and I said, let's let the surrogate pick who they want to work with. And I was able to get the dropout rate down to 1%. Because now the surrogates are saying, I like these intended parents. I want to work with them. And intended parents still fall in love with the first person they meet.
Yeah.
But now they're meeting a better person who's picked them, which is, by the way, the best part of Nodal is that you actually get a phone call or an email being like, there's a surrogate who wants to help you. Instead of getting an email or phone call from an agency saying, oh, we found someone that you will work with. You see the difference there?
Oh, totally. It's very different.
Number 2, surrogates in America are asked to fill out their medical information on a survey. Sometimes it's type form, whatever, but like they fill out their information.
Mm-hmm.
And then they're told, go collect your medical records. Now, that's great if you have a motivated surrogate, but you're asking her to collect her medical records. And you and I both have delivered enough kids to know that not every delivery goes smoothly. But if you want to be a surrogate really badly, you have the opportunity here to choose which medical records you're submitting.
Interesting.
And so what happens is the surrogate that's presented is not always the surrogate that is actually sitting in front of you. And as a result of that, clinics sometimes will reject a surrogate because they're like, wait a second, we're going to pull all the health data, get us your medical records, get us your delivery notes. And then when they finally read the delivery notes, they're like, whoa, she had preeclampsia, she had preterm delivery. So on the Nodal platform, what I did was I said, you know what? We're going to look at objective data. We're going to look at something called claims adjudicated data, which for the listeners in plain English, that means your insurance data. Because no hospital forgets to bill for a C-section.
Yeah.
No hospital forgets to bill for a blood transfusion. No hospital forgets to take note when they bill for a NICU admission. And so by pulling the claims adjudicated data, we're looking at objective data to help us better assess that surrogate. First of all, it removes the pressure from the surrogate of collecting her records. B, it provides us objectivity to something so subjective and objective at times. And then we get to build a profile to make sure that we actually have the person who's sitting in front of us that actually is the person there.
Yeah.
You know, quite often, and I'm sure you and I both know this, pregnancy stinks. And after pregnancy, there's mental health problems. But no one reports their postpartum depression. But if you see that someone has refills of sertraline, then you want to make sure that they're okay to proceed with another surrogacy journey.
Yeah.
And in fact, the American Society for Reproductive Medicine says that you should not be on any psychotropic drugs if you're going to pursue surrogacy, because they want to protect the mental health of the surrogate. But so often surrogates fail the evaluation because no one asked what drugs they're using, like prescribed medications.
Yeah.
So by us pulling their healthcare data, we remove that awkwardness yet again. And we empower them to say, you are who you are, and we know you are. And so it gets us build up the women in front of us. But I have to bust a myth for you.
Please.
The most common myth that people say is, great, so you know how to vet, you know how to screen, you know how to match. But are these just women trying to make easy money? And the answer is, you can make $55,000 to $60,000 much easier by doing a lot of other things. Like, you can go work in an Amazon factory and work 1 day a week, or there's a lot of things you could do. The number one reason that people want to be a surrogate is because they want to be able to have extra capital available to support the family that they have. Surrogates are moms.
Yeah.
Surrogates have kids. Surrogates have families. And the number one reason we hear as the motivator for why people want to become surrogates is they have this sense of altruism. They want to help other people. And they loved being pregnant and they love the experience. But more importantly is they want to provide for their kids sometimes what they forgot to do, which is to save for college. Sometimes to save for other expenses. So together, surrogacy is a beautiful opportunity to help people accomplish their family goals. And to help people accomplish their goals of growing their families.
Yeah. Yeah. I think that's so wonderful. Hearing you, Brian, I think about two personal friends who went through surrogacy for similar reasons that you alluded to, whether it's because of a medical condition that that was congenital, that they were born with, versus issues with just trying to conceive, and them sharing to me their struggles, their frustrations. The cost was a big piece as well. But one friend also shared how the biggest positive she had in her surrogacy journey was recognizing the altruism, how many people kind of poured into supporting her and her partner's desire to grow a family. And many more people are involved when you choose or need to use surrogacy. So it's not only the intended parents and the surrogate, but it's also the clinical team. There's also lawyers involved. Can you kind of speak to the kind of outer ring that surrogacy involves, specifically, the legal aspect?
Sure. So do you remember I said to you before that I'm the product of a community of mentors? I believe that. No one person got me here, and I didn't get here myself, right? Like, it took a village. And when it comes to gestational surrogacy, it takes a village. And you have lots of different participants. You have fertility doctors, sometimes at two different clinics, right? Like the clinic that the surrogate lives near and the clinic that the embryos are in. Sometimes you need to get, mental health providers and social workers and, PhD psychologists involved. But almost always you need to get lawyers involved. And you need to have legal protections. So lawyers are amazing because what they can do is they can remove every grandmother's biggest fear. What if she keeps the baby?
Yeah.
Well, let me just tell you right now, no surrogate's doing this because they want to keep a baby.
Yeah.
No one's getting pregnant because they want to keep someone else's kid. If they wanted more kids, they're typically fertile. They could have more kids.
Yeah.
But every grandmother that's expecting a kid through surrogacy wants to know there's legal protections for that kid. But lawyers do other things. I'm a diehard advocate for patients, and I don't think people appreciate enough that in the surrogacy world and the third-party reproduction world, lawyers are advocates for the donors and the surrogates. And what they are doing is trying to protect the needs and rights of those surrogates, making sure that a birth order is in place. So what most people don't know is that gestational surrogacy is state by state, but also county by county. And in some places, there needs to be a medical indication. So like in the state of Illinois, you actually cannot go through surrogacy unless you have a medical indication for why you need to work with a surrogate. So social surrogacy, right? Just choosing not to be pregnant is not appropriate.
Thank you.
Now, you can use the medical term tocophobia, which is fear of labor contractions, and that is a medical indication. So you just have to diagnose your patient with tocophobia.
Yeah.
A good word you're going to probably take away from this
I was
one
going to
today.
say, I'm just learning so much from you, Brian. Great. Tocophobia. Here we go.
So if you diagnose your patient with tocophobia in Illinois, then you have a medical indication, because then they have a fear of pregnancy. But it's actually county by county and state by state. And you need to have lawyers that are licensed in the county and the state where the pregnancy will end, which is delivery. And you need to make sure that there's adequate protections for the intended parents in the state that they reside. So it typically is 2 sets of lawyers, one for each side. The lawyers typically are friends, because it's a really small community of really amazing, awesome people who all kind of know each other. And typically most of the agreements are boilerplate. But sometimes there are important things to think about. Let's just say, for example, you're a surrogate that doesn't live near a tertiary healthcare center, and your intended parents feel really strongly that you need to be at a place with a level 3 NICU, for example. Well, the surrogate has every right to say, I would like my transportation to be covered so that its cost is not an issue for me, to make sure that goes in the contract. If you want to make sure that your surrogate doesn't take public transportation because you're so worried about colds and flus and viremia and all these other things that can happen during the winter months, you can say that I want my surrogate to only use an Uber, and we will pay for it, and put that in the contract. But more importantly, the surrogate is protected for her financial resources through escrow. And the escrow is typically run either in California, a lawyer is allowed to actually run the escrow, or in the rest of the country through an escrow business that works with the lawyer. So the lawyer makes sure that the surrogate achieves certain milestones. And when they achieve those milestones, then they actually get to work on the next step, which is payment. And you release the funds from the escrow.
Yeah, very interesting. Ooh, I am like nerding out. I hope whoever gets the honor of listening to our episode nerds out with us, because I'm learning so much. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. What, in your experience, what I love about Nodal is it seems, from what you've explained so far, it seems to kind of prioritize both the parents and the surrogate, which is so important. What makes a good surrogate? I think you alluded to a couple of things about their medical history that might mean that getting pregnant is too high risk, but what would make a good surrogate?
So a good surrogate, in my opinion, is a good person. First and foremost, they got to be motivated the right way. They have to want to help someone, which, by the way, is not everyone. And that's okay, right? Like, not all of our friends became doctors. Not all of our friends became nurses, right? Like, you don't have to be a helper, but they have to be motivated and oriented towards wanting to help people. First and foremost. Second, they need to be a mom. They need to have living children who are healthy and have had uncomplicated pregnancies and postpartum courses. You know, another great factoid for you. The average surrogate goes back to work 2 weeks postpartum. That's crazy.
Yeah.
Surrogates experience all the physiological changes of pregnancy, all the physiological changes of the postpartum period. But because they go home with no child, they typically feel societal pressure to go back to work very quickly. And so it's a fascinating, right? This is fascinating. The postpartum period of surrogates. By the way, the reason that Nodal partnered with Maven is because we're able to deploy healthcare resources and mental health resources, because we recognize that there's still all the hormonal shifts that are occurring. And we want to put some bubble wrap around those surrogates so that they actually can have a postpartum transitionary period that's safe and effective to protect them. So number one is a nice human. Number two is a healthy pregnancy with healthy kids at home. Number three, stable food, stable housing. You cannot be on government subsidy. You cannot be doing this because you need to go find 50. You can't be doing this because you can't make your mortgage payments and you're going to go to a shelter if you don't have the money. Stable home, stable food. And last but not least, You need to be able to meet the criteria of the clinic of the intended parents. And people forget this because there's a lack of oversight and regulations in America. By the way, like, you don't hear people often asking for regulations. And so, like, for any government people listening, like, please, like, help, like, please help standardize this.
Yeah.
But today, of the 450 clinics in America, there's probably 451 opinions on the best surrogates. And it's really hard.
Yeah.
And so what might be the ideal surrogate at one clinic is not the ideal surrogate at another clinic. An example for you would be a BMI of 31 might float at some clinics, but other clinics will say you have to be below BMI of 30. Some will say you have to be under 35. Some will say you can be up to 39. Some will say you have to have less than 5 deliveries in the past. Some will say you'll have up to 5 deliveries in the past. Like, it gets really down in the weeds and minutia.
Yeah.
So I'd say that last part is always the hardest part for me, because you can find the ideal candidate that you want to partner with. And by the way, that's why the way I view surrogacy is this is partnership.
Yeah. Collaboration.
Like, this is a partnership. This is a jointly oriented goal for someone. But even the most perfect surrogate on paper may not pass the criteria of a clinic, because the clinic criteria might be different than what is expected. And that's fine. So then you just got to find the right clinic.
Yeah. Yeah. Something that you've talked about a lot is the costs, right? That the costs have gone up exponentially without it actually benefiting the intended parents, the surrogates. And likely a big portion of those cost increase, have they gone to the brokers and the middlemen? Where's the money going, Brian?
So I have 2 kids at home. And, like, you know, my favorite title of all the titles that I have is dad. You know, and if I have to rank them, it's father, husband, founder, doctor, right? Like, in that order.
Yeah.
Raising kids is really expensive. Raising kids is also really hard. And it kills me that intended parents will overpay and have services under-delivered because they think that money greases the wheels of time to make things move faster. And so on the Nodal platform, I've been oriented towards cost savings from day one. And because we are technology forward, we're an 8-person team as opposed to these agencies that have, 25 and 50 employees. Yeah. And by the way, the average agency in America does 25 matches a year. We've already done over 100 in our year and a half since we got launched.
I believe it.
And so for us, what I tell people is money doesn't buy you anything more than making someone else have a nicer car at the agency. And instead, you should understand what you're paying for. And by the way, some people need the gold glove experience. They need their hands held, and they should pay for that. But if you can't afford that, that doesn't mean you can't have a baby through surrogacy. And so in Nodal, what we have done is we've really tried to get the cost down as low as possible. And one of the ways that we've done that is by limiting the administrative fees. The second is we've actually bifurcated the process. People can use Nodal for just matching with a surrogate, finding the right surrogate. And then they can do what's called an independent journey. And they can kind of do it on their own. And they can go work with a lawyer. And they don't need us to do case management. Or they can bolt on case management. But together, the 2 services with us for matching and case management come together at $30K. And $30K is around 45% of the industry standard today.
Yeah.
And that $30K has been designed as a way that if you have an employer-based benefit solution towards surrogacy, we want you to have that covered. So we're trying to go for the lowest price possible to make sure that you can use your benefits so you don't have to come out of pocket whenever necessary. In the end of the day, we believe that the play to make for Nodal is on volume. We're not making the play on Nodal to say, let's charge our customers the most that we can. We're saying, let's try to charge the least that we can and service the most people possible.
Yeah.
And that's why we are a venture-backed company, right? Like, that's what we're doing. Like, this is let's not get confused here. Like, this is a business and we are a successful business, but we are trying to reduce cost and improve speed and financial efficiency at every turn of the wheel. And that's what we do.
Yeah. Brian, I think about, I alluded to my aha moment, why I'm an OBGYN, why we're talking today is because of disparities, health disparities, recognizing that it's inequities that can continue to widen the divide and conversations I've had on the podcast and just in life is recognizing there are people who want to or need surrogacy to build their families and can't because it's so cost prohibitive. And so what you are doing with Nodal is breaking that down. I mean, 30K as opposed to 250K, I think is one example that you gave. That's wild. That's so different. And you're creating opportunities for people who otherwise wouldn't be able to start the families that they want.
So just to clarify, to be clear, the 30K is for the administrative fees. Of course, there's still the compensation for the surrogate. There's still the medical expenses for the surrogate, the legal expenses for the surrogate. But if you look at our all-in, we're running probably around 100 to 110 compared to the industry standard of 250, 300.
Yeah.
And there's another reason. So there's some really cool companies out there, like Sunfish, for example. Like, I don't know if you know them at all. They're in the Bay Area. And so Sunfish is a company that can help people borrow funds to be able to close the gap in fertility care. So the largest loan that you can take typically for healthcare, which basically ends up becoming a home equity loan line of credit or a HELOC against your home, is about 100K. And so by helping to bring the whole process closer to 100K, if you can't afford the 100K on the Nodal platform, we teach you how to borrow. We teach you how to get to the resources so that you can do it. And the whole goal here is to put money in the pocket for the surrogates. So we actually encourage our surrogates to ask for compensation that's approximately 20% higher than industry standard. So our surrogates are paid well because we want our intended parents to pass these cost savings on to the surrogate.
Yeah.
Right? Happy surrogates, happy intended parents, better relationships, better partnership all the way around. But second is we realize there's a lot of bloat in the industry, and we've trimmed that bloat away.
Yeah. Thank you for clarifying the cost breakdown. It's still a huge savings, which is still a huge benefit for all parties involved. We've touched on a lot of the logistics of this process, the players, the costs. Can you speak more to the emotional journey that intended parents go through, and the surrogates themselves? These are, as you said, it's a collaboration, it's a partnership.
So I told you we're an 8-person team, right? Almost everyone on our team has been touched by fertility services. Either you have our general counsel, who is a intended parent through surrogacy herself, after having 27 unsuccessful embryos transferred into her over years, to our intake coordinator, who's a surrogate herself 2 times, to our community manager, who's a surrogate herself, to even on our tech platform, even on our leadership team. Everyone's kind of been touched by fertility. And it was important for me to build a team of people who've had the experience firsthand, because this is so emotional. There is so much trust that needs to be built quickly and efficiently, and trust that needs to be earned quickly and efficiently, because the process needs to move. And so the emotional toll of surrogacy is one where people today, off the Nodal platform in the traditional model of agencies, hurry up and wait. And that sucks because it feels like it's never going to happen. And so they sometimes end up with an empty wallet and an empty nursery because they never get that kid that they dreamed about. And you sometimes have to service those people who are so broken when they come to you with their tail between their legs and they're like, I don't know how I ended up here. I paid all this money to an agency. I waited 2 years and I never got a match. And then, of course, they match on the Nodal platform in 45 days and they think we're lying to them. They're like, how did this happen? Is she real? And I'm like, oh, you can meet her. She wants to meet you.
Yeah.
Which is like the coolest thing ever. In the same regard, the emotional toll of all of this is a lot. So that's why you have to partner with community leaders and psychologists. And so on the Nodal platform, we assign every surrogate to a prior surrogate, and we call them mentors. They get a buddy who's been through it. So you get someone to say, like, what's it like when you deliver? What's it like when you go home without a baby? What's it like to go to an OB appointment and it's not your kid? How do you explain this to your own kids? How do you explain this to your own mother? How do you explain to your parents that they're not going to be grandparents again, but you're going to be pregnant again? And what we've learned is that by building community, you get to take the emotional part and make it a beautiful part.
Yeah.
Because you actually help build a stronger community because we're putting people into that community every day.
Yeah. Lovely, Brian. Help me. You've taught me a lot, but help me as an OBGYN and any other general OBGYNs like me listening to be good providers, right? Because by the time we see the intended parents and the gestational surrogate in our office, everything else has already happened. They've successfully conceived, and now we're just supporting them through the pregnancy and delivering them. What should the OB team do to support these families? How can we do that as respectfully as possible?
So I've thought about this a lot. And I tell everyone there's 3 pointers that I ask all OBGYNs who are care providers for surrogacy to please follow. Number 1, please strike the word use from the language. Your intended parents are not using a surrogate. They're working with a surrogate. They're partnered with a surrogate. This is not the Handmaid's Tale. This is not, indentured servitude. This is a woman who volunteered to be a hero to someone who dreamed of having a family.
Yeah.
And heroes need to be respected. And so it kills me when people say to an intended parent, why are you using a surrogate? I hate that. I really hate that.
Yeah.
But more importantly is, if all the listeners can just remember that, we don't use humans. We work with humans. We collaborate with humans. We partner with humans. And surrogates are moms to show them the respect they deserve. That's number 1.
Yeah.
Number 2, the intended parents are expectant parents, and they deserve to be treated as such. There is so much bias that goes to the person with the belly, but people forget the other people who are in the room. And remember that the emotions that happen when a family is starting or growing or being completed are the same no matter who's pregnant. And treat those intended parents the same way you would treat any other patient. They're excited and they're scared, and probably more scared than excited. But they're hopeful. And don't break their hope by only focusing on the surrogate that's in front of you. Include them in the conversations. Include them in the discussion. And number 3, understand that today it is highly complex, and it is okay to not understand the nuances of the relationships and the process. But there are people who are there at a moment's notice to help you understand, which means that if as a doctor, you're taking care of a surrogate and you're like, wait a second, I don't get it. What am I doing here? What's my responsibility? Who do I hand the baby to? What do I say? Say it. Don't fake it. Say it. And know that you can call the lawyer for the surrogate. You can call the lawyer for the intended parents, and you could ask them, hey, how should it all go down? What is the steps? What is the plan? And in fact, talk to your hospital. Hey, what's our plan for surrogates? Example, many hospitals don't provide a postpartum room for the intended parents. They treat them like grandparents. Many hospitals wheel the baby back to the surrogate after she delivered. There's a lot going on here. There's a lot of coordination that goes on here.
Yeah.
This is a multidisciplinary approach. What name is on the bassinet in the nursery? So if as an obstetrician, this is your first time taking care of a surrogate, take that opportunity to say, I don't know. I know medicine well. I know how to deliver. I know how to get a safe baby out. But let me go find out what I can do to make sure that you have the best experience possible.
Yeah.
So ask questions, ask for help.
Yeah. I always say it's so humbling being a human that gets the honor of caring for other humans. And part of that humility is asking questions and acknowledging what we don't know. And that takes courage. It takes courage. Brian, I am very selfish taking so much of your time, but I have a couple more questions. Thank you. One thing that have been so amazed by when I compare kind of postpartum care in the US versus abroad is parental support, parental leave. We have good friends who live in Europe, Germany, Finland, where moms can have an entire year, up to a year postpartum paid leave and beyond. And so I'm oftentimes making this comparison of postpartum care in the US versus abroad. When you compare kind of fertility care, specifically surrogacy in the US versus abroad, are we ahead? Are we behind? Is everyone behind? And Nodal's the only one, pushing forward. Or is there anything we can learn from our colleagues in in Europe or abroad?
So proud to be an American. I love living here. When I was in medical school, I spent 6 months in Ghana. I got to experience healthcare in a different way. It was important to me to go to a place where I didn't look like everyone else, where I could actually be uncomfortable in my skin, because in the United States, I'm kind of the norm. And I feel like I wanted to learn what it's like to be on the other side. And so I spent a lot of time for personal growth and development, being in Ghana and learning the healthcare system there.
Good for you.
I go to India a lot. I go there once a quarter to actually see patients, because there's a huge fertility problem in India and they're still in their infancy stages there. But I always feel such comfort when I land at JFK, because I feel like this is the land of opportunity. And again, surrogacy is the land of opportunity that's only pretty much legal here in the rest of the world. The world is moving in a direction that is halting surrogacy. Gestational surrogacy is illegal in India. Gestational surrogacy is illegal in China. Gestational surrogacy is illegal in Russia. Gestational surrogacy is condemned by the Roman Catholic Church and the Vatican. Gestational surrogacy must be done without compensation for the gestational carrier in the UK, in Canada, and much of Western Europe. And only in the United States do you have contractual relationships that protect the rights of all three parties: the intended parent, the carrier, and the child. So what we're learning from the rest of the world is that they're prejudiced and that they don't understand that there's a lot of people out there who need to work with a surrogate. What we're learning out there is that a lot of the world is myopic when they make these really bizarre rules, because they don't want to deal with the legal sticky wicket of what's going on. And what they're doing is they're actually pushing surrogacy to some really dark places. For example, the capital of surrogacy worldwide in 2021 was Ukraine. That was the world's capital of surrogacy, the capital. More surrogacy happened in Ukraine than anywhere else on earth. And then they had a war. And of course, no one thinks it's a good idea to put an embryo into someone to have them stay in the Ukraine, because Ukraine had the legal protections actually for the intended parents and the gestational carers. The Ukraine actually has beautifully well-written rules, regulations, and laws and policies to protect all three parties like the United States. But it was at a fraction of the cost. So what's interesting is what happened was many Irish and Australians who can't do surrogacy in their own countries would go to the Ukraine for their gestational surrogacy journeys. And then when the war started, they all ran to Poland, the most conservative country in Europe, who has made surrogacy illegal. And it ends up that when a surrogacy case occurs in Poland, you have to have an adoption occur. So the child is actually the child of the surrogate, and she has to give the child up for adoption, and then the intended parents have to adopt the child. And the only way you're allowed to do an adoption in Poland is if you're a landowner. So you actually have to own land in Poland.
Oh, that's so messy.
And that is just the beginning of what happens worldwide. We can talk about the fact that in India, you had people who are faking that their cousins were their surrogates because you could only have a family member carry for you. Or in China, people actually had these surrogacy hospitals where they were locking surrogates up to keep it all under wraps so that it actually didn't get out. The surrogates were happening there. Or people go in Mexico to actually go do gestational surrogacy, and they sign legal documents they find out that are fake, that the documents don't actually exist because the laws in Mexico don't actually protect the intended parents at all. They only protect the surrogate. Or people go to Colombia to go do gestational surrogacy because there's no laws whatsoever. So they actually just go what they call barebacked, and they just assume that it's going to be a bumpy ride, but it's going to be okay, and they'll figure it out. It's terrible.
Brian, I'm stressing.
So to anyone who's listening, you should be so proud to be in this country. But more importantly is, if you can't get pregnant, or you won't get pregnant, or you shouldn't get pregnant, and you need to go through the path of surrogacy, do it here. Do it in the US. It's the safest place on earth.
Yeah. Brian, you got my blood pressure up just thinking about what people have to go through abroad. That's so stressful. That's so scary. And I want to end on a positive note. As we wrap up, tell us, you've given us kind of little tidbits of all the amazing things that Nodal does, but can you give us your Nodal spiel? How can we find you? Tell us again, just a summary of all the amazing things that you guys are doing and how you guys are helping intended parents and surrogates.
Absolutely. So first and foremost, thank you. Thank you for listening. Thank you to everyone else who's listening. And thank you for thinking about starting or growing or completing your family through surrogacy. And for those people who thought it wasn't possible, just realize that there's a solution out there that's trying to make ends meet. We're trying to make it more affordable, more accessible. Since we got started, we've saved our intended parents over $5 million in agency fees alone. We've saved our intended parents over a century collectively of waiting time. But more importantly is, we have a bunch of really cute kids to prove that our process works. To me, the proudest moment being a founder, and by the way, I've never taken a penny from this company. I've only invested in it. I've never actually had a salary or a dollar or anything because I care so much that all of our dollars that we generate go back into this company to making it better, to making it stronger, to making it truly the best inclusive solution for surrogacy in America. But more importantly for me is what I'm proudest of is that we're a team of people who actually care. People who've been through it, either people who work in the industry, who've gone through surrogacy, who've been surrogates themselves. And so there's no question that's silly. You can find us on Instagram at Nodal Surrogacy. You can find us online at nodal.com. You can find me at drbrianlevine@gmail.com. You can email me, I'll answer you, or you can go onto my Instagram at drbrianlevine. But if you're thinking of pursuing surrogacy, you should know that you have a bunch of dedicated people at Nodal who want to help you achieve your goal. And even if you just want to get educated, we'll do that too. We'll just talk to you about it. And you can come back when you're ready. And we're happy to help. Because most importantly, I am so privileged and so honored to be able to do what I do every day and to love it.
Your enthusiasm and your passion for what you do is infectious. I'm on a high right now. It makes me want to go to work, deliver a couple of babies, do a couple of ectopic surgeries. Like I feel like there's so much I can give back to the community that I have an honor to serve because you are doing that with the community that you have honored to serve. So grateful that our mutual friend Eduardo connected us. So grateful for all those who've gotten to listen over the past hour, to learn from you, to be inspired by you, and also they're leaving with hope. I think there are people who are listening and who are leaving with hope and with that faith that they're going to be able to start the families that they've always wanted. So grateful for your time and your wisdom. Appreciate you.
This was so much fun, but most importantly, this is me.
Yeah.
I just put it all out there and I know it's not for everyone, but I hope one person, just one, has a little spark that's lit that's like, I'm going to do this. And we're happy to help that person.
Yeah. I believe it, Brian. I believe it. You've given me chills so many times in this conversation, but I really think that there's going to be more than one people moved by this. So thank you again, my friend.
Thank you so much. Have a great day.
You too. Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.